Hello students, welcome to this session. I am Dr. Rajeshri Mutha, Department of Microbiology. So in 1883, Klebs first observed Corynebacterium diphtheria, and then 1884 Loeffler first cultivated Corynebacterium diphtheria, and that is why this bacteria is also called as Klebs-Loeffler bacillus. In 1888, Rox and Ursine established the pathogenic effect of diphtheria toxin, and 1890 von Behring described the antitoxin. So the gram-positive bacilli, they are non-capsulated, non-sporing, non-motile, and they are irregularly strained and frequently show club-shaped swellings at the end of the bacteria. Coryne means club and diphtheria means leather. So Corynebacterium diphtheria causes disease that is called as diphtheria. It is leathery type of pseudomembrane formation. So the occasion pathogenic other bacteria are Corynebacterium ulcerans and Corynebacteria pseudotuberculosis. So morphology of Corynebacteria, they are club-shaped, irregularly stained, gram-positive pleomorphic rods. Usually the arrangement is in V or L form, and it is also called a Chinese letter or cuneiform arrangement. And then it is because of the bacterial division takes place, but these daughter cells, they are not separated and they remain at acute angle, that is V and L shape. It is also called a snapping type of division. These metachromatic granules, they are present at the end of the bacteria, also called as polar or Babes Ernst bodies or volutin granules. They are present at the ends or poles of the bacilli. They are storage granules and they contain polymetaphosphates. They are strongly gram-positive as compared to the other part of the bacteria. They are stained by Loeffler's methylene blue. They appear as bluish purple metachromatic granules. And special stains for these granules is Albert, Nizar or Ponder stain. And they are properly developed on enriched media like blood agar or Loeffler's serum slope. So inhibition of translation step of protein synthesis, and this is a mechanism of diphtheria toxin. The factors regulating this toxin production are phage coded bacteriophage. It is also called as beta corynephage. It carries tox gene. Then iron concentration, it should be 0.1 milligram per liter. If the iron concentration is increased, it is causing negative effect. Then DT repressor gene, that is negative regulator. Biotypes like Graves, Intermedius, Mitis all produce this toxin, and other species are also producing toxin. They are Corynebacterium ulcerans and Corynebacterium pseudotuberculosis. This toxin can be converted toxide, which is used for the vaccination. So what is toxide? Toxide is a form of toxin in that virulence is lost but antigenicity is retained, and this is made by use of formalin, acidic pH or prolonged storage. So this is a mechanism you can see here. Corynephages controls toxin production. Then here you can see this A part diphtheria toxin is enter after the binding of this B part to the cell membrane, and then it activates elongation factor 2, and it prevents protein synthesis by ribosome and ultimately cell death. The pathogenicity of diphtheria, it is a toxemia, not a bacteremia. That is disease of diphtheria caused by toxin produced by Corynebacterium diphtheria, that is diphtheria toxin. These bacilli are non-invasive. They secrete toxin and then which spreads to the various organs through bloodstream, and this toxin is responsible for all type of manifestations like local, that is respiratory, and systemic complications. In that the pseudomembrane is formed. The toxin causes necrosis of the epithelium and produces exudate, and then causes ulcers. They are lined by the tough leathery greyish white pseudomembrane coat, and in this it is surrounded by neutrophils, RBCs and bacteria. So it is called as pseudomembrane because it is difficult to remove that membrane, and while removing it causes bleeding. So it is called as pseudomembrane. The incubation period of this disease is 3 to 4 days, and different sites are there like fascial. It is a commonest site. It consists of tonsil and pharynx, then laryngeal, nasal, otitic, conjunctival, genital like vulval, vaginal, prepucial, and cutaneous. So these are the sites of the disease. Then in clinical manifestations, most common manifestation is facial, and in that respiratory diphtheria is there. So tonsil and pharynx are involved, and then nose and larynx, the common site. Incubation period is 3 to 4 days. In facial diphtheria, pseudomembrane is adherent to the mucosal base and it bleeds on removal. It is extending to larynx and bronchial airways, and therefore it causes bronchial obstruction and then may cause asphyxia. There is bull neck appearance. The tonsillar swelling and neck edema causes bull neck appearance of the disease in the patient, and the symptoms are foul breath, thick speech, and stridor. So here you can see this white patch, that is pseudomembrane, and in this child you can see this bull snake, that is cervical adenitis. So this is a boy 10-year-old with severe diphtheria. So in that conjunctivitis, pharyngeal membrane is there, and then bull neck, severe myocarditis, and all vaccines contraindicated. Here you can see this white patch, that is pseudomembrane formation and bull snake in this child. The other type of diphtheria is cutaneous diphtheria. It is punched out ulcerative lesions with necrosis due to organism itself and not because of the toxin. It may be caused by non-toxigenic strains. Increasing incidence in especially in vaccinated children, because antitoxin cannot prevent this disease because it is not toxin mediated, it is because of the bacteria. In pathogenicity, according to the clinical severity, the disease is divided into 3 types: malignant, septic, and hemorrhagic. So in malignant, there is severe toxemia with marked adenitis and death due to circulatory failure. In septic, there may be ulceration, cellulitis, gangrene around the pseudomembrane. Hemorrhagic, bleeding from the edge of the membrane, or sometimes other sites like epistaxis, conjunctival hemorrhage, purpura, and generalized bleeding can be there. So these are the 3 types: malignant, septic, and hemorrhagic part of the diphtheria. The systemic complications, mostly they are neurologic manifestations. They are toxin mediated, non-inflammatory demyelinating disorders of cranial nerve involvement, peripheral nerve involvement, and ciliary paralysis. There can be myocarditis. This typically associated with arrhythmia and dilated cardiomyopathy. The complications of diphtheria are asphyxia because of the mechanical obstruction of the respiratory passage by pseudomembrane. Acute circulatory failure may be peripheral or cardiac origin because of the toxin, and post-diphtheric paralysis may be palatine or ciliary muscles are involved, and there is spontaneous healing can be there in 3rd or 4th week. Septic complications like pneumonia, otitis media can be there. Laboratory diagnosis. So this is a risk of respiratory obstruction can be there. So treatment should be started immediately on clinical suspension without waiting for the laboratory reports. The laboratory diagnosis is necessary only for the confirmation of clinical diagnosis or initiating the control measures and epidemiological purpose. So in lab diagnosis, there are 2 parts. First is the isolation and identification of the bacteria, and second is the toxin demonstration test. So this isolation and identification method, 2 swabs are collected using a tongue depressor from a pseudomembrane part in a sterile container. And in toxicity testing, they can be in vivo or in vitro testing. So here you can see this tongue is depressed with the help of tongue depression, and then white patch you can see. So from that you have to remove the exudate with help of swab. So the specimen can be throat swab containing fibrinous exudate and portion of pseudomembrane. So first step after the specimen collection is direct microscopic examination. So it can be done by different staining methods. So first gram staining. So in that you can see gram positive bacilli arranged in Chinese letter pattern, that is V or L pattern, and irregular staining with clubbed at the ends of the bacteria. In Albert stain, the bacilli are green in color, and at the end you can see metachromatic granules. They are stained bluish black in color. Neisser stain you can see here. So red color bacteria and metachromatic granules are bluish in color. Then you can do culture inoculation. So the bacteria is fastidious, aerobe and facultative anaerobic bacteria. So the first method can be enriched media. So it can be blood agar or chocolate agar. On that you can see small circular white color colonies. The second media is Loeffler serum slope. So nutrient broth with horse or serum is added in that and glucose. So colonies may be seen 6 to 8 hours. It is a base medium for the metachromatic granules production. Disadvantage, if it incubated more than 6 to 8 hours, then there can be growth of throat commensals. So next is a selective medium. So that is blood potassium tellurite agar. So in that you can see black color colonies because potassium tellurite acts as a inhibiting agent. So only Corynebacteria diphtheria is selectively grown. So this potassium tellurite is reduced to metallic tellurium, and that is black in color, and so the color of the colonies is black in color. In biochemical reactions for the identification of Corynebacterium diphtheria, it is catalase positive but oxidase negative, and on his serum sugar media used for the testing sugar fermentation. So diphtheria bacillia ferment glucose and maltose all types, and starch is fermented by Graves type only with production of acid and no gas. Urease test is negative in Corynebacterium diphtheria, but it is positive in C. ulcerans and C. pseudotuberculosis. Now next step is toxin demonstration. So it can be in vivo or in vitro test. So in vivo by use of animal, that is guinea pig. So it is of two types, subcutaneous inoculation or intracutaneous inoculation. So in subcutaneous inoculation, it leads to date of the test animal within 4 days. So this method is not used. The second method is intracutaneous inoculation. There is necrosis at the site of the injection, and within 48 to 72 hours, and there is no death of animal, and many tests can be tested at the same time in the same animal. This is the advantage of this. In vitro test, the best method is Ilex gel precipitation test, or detection of tox gene by PCR method, or detection of toxin by ELISA or immunochromatographic method, or tissue culture method. So these are different in vitro tests. So in vivo test by use of animal. So in that, the test animal is given injection 5 ml of diphtheria, C. diphtheria cell suspension. Control animal is given injection 1000 units of Corynebacteria diphtheria antitoxin and 5 ml of C. diphtheria cell suspension. So the animal is dead and control is alive. So that is toxigenic strain of the C. diphtheria. Test alive and control alive, so that is non-toxigenic strain of the organism. Test dead and control dead, so that it may be because of the toxicity not due to C. diphtheria, some other reason is there. In vitro test toxin demonstration, so that is Ilex gel precipitation test. So it is immunodiffusion in gel method. So in that, petri dish with 20% horse serum agar is taken, and on that filter paper soaked with diphtheria antitoxin is applied in the center, and then streaks are done right angle to the disc, that is test strain, the toxigenic strain and non-toxigenic strain. So non-toxigenic strain will not show precipitation, toxigenic strain will show line of precipitation. Where the toxin and antitoxin meet, there is formation of precipitation band. Then biotypes of Corynebacterium diphtheria are 3. They are Gravis, intermedius and mitis. So morphology, they are short, no granules, long barred and poor granules are there, and the mitis long curved and prominent granules are there. Colonies on blood potassium tellurite agar, the Gravis shows daisy head type of colony, intermedius frog's egg like colony, and mitis shows poached egg colony. The colony consistency in Gravis, it is brittle, not emulsifiable. In mitis, it is soft, buttery and emulsifiable, and in intermediate, it is in between Gravis and mitis. So not very brittle and not very soft. Then starch fermentation is done only in Gravis, intermediate and mitis, they are negative. Toxigenic strains, Gravis, they are 100% toxigenic strains, intermediate 95 to 99%, and mitis, they are 80 to 85%. Virulence in Gravis, it is severe, In intermediates it is moderate, and in mites it is mild. The occurrence of disease in gravis it is epidemic, intermediates it is epidemic, and mites is endemic. Complications in gravis it is paralytic and hemorrhagic. Intermediates it is hemorrhagic. Mites it is obstructive type. Hemolysis in gravis is variable. In intermediates it is non-hemolytic strain, and mites is hemolytic. The incidence are decreasing widespread use of the vaccination coverage. The source of infection is carriers 95% and 5% from the cases. The carriers they are temporary, persist for a month, and chronic persist for more than for a year. The nasal carriers are more dangerous because they shed frequent bacilli and throat carriers. After that, the throat carriers. Transmission is through aerosol or sometimes through the contact that causes cutaneous diphtheria. The reservoir of this disease is humans only. The age is common age affected is 1 to 5 years, and newborns are protected because of the maternal antibodies. The global situation, due to widespread immunization, cases are drastically declined by more than 95%. Currently, there are around 5,000 to 5,500 cases occur per year since 2005. But in India, it is highest burden, 60 to 70% of global diphtheria. 2016, there were 3,380 cases were there. The highest burden is from the Uttar Pradesh and Kerala and Karnataka. Maximum cases are of age 5 to 10 years. This may be because of the poor vaccination or the low immunity leading to adult diphtheria. The treatment it is of two types. You have to start it immediately on the suspicion of diphtheria. The first is anti-diphtheric serum, that is antitoxin. It is a passive type of immunization, and in that it neutralizes the toxin. The trial dose is given to check the hypersensitivity reaction, and then in mild infection, that is early pharyngeal cases, it is 20,000 to 40,000 units, and moderate severe cases it is 40,000 to 60,000 units, and severe extensive and late cases, that is more than 3 days, it is 80,000 to 1 lakh units given. Antibiotics, penicillin or erythromycin is drug of choice, but antibiotics plays minor role in this disease treatment because it is toxin mediated, not by bacteria. Antibiotics are useful if given less than 6 hours of infection before the toxin release. So it prevents the release of toxin by killing these bacilli, and it is treatment of cutaneous diphtheria, and in carriers erythromycin is the drug of choice. Now prophylaxis is because of the vaccination. So diphtheria toxoid is used in the as a vaccine. So there are 3 types of vaccines: the single vaccine, combined vaccine, and pentavalent. Single vaccine it is diphtheria toxoid, alum or formal precipitated vaccine. Then combined vaccine it is DPT, that is diphtheria pertussis, that is whole cell, and tetanus toxoid. DAPT it is diphtheria, tetanus, and acellular pertussis. Then DT is diphtheria and tetanus. Small dt it is tetanus and adult diphtheria toxoid. Pentavalent vaccine contains diphtheria, pertussis, tetanus, hepatitis B, and Haemophilus influenzae type B. So, some little detail about DPT vaccine. So the types of DPT vaccine are plain formal or adsorbed on alum. So schedule is given in 3 doses in the beginning, that is 6 week, 10 week, and 14 week of the birth, and then booster doses at 16 to 24 months, and then the second booster is at the 5 year, that is at the school entry. Then site is deep intramuscular at the anterolateral aspect of the thigh. So here you can see this baby, it is immunized by DPT at the anterolateral aspect of the thigh. The second method is passive prophylaxis, that is by using anti-diphtheric serum. So subcutaneously 500 to 1000 units are given. It is prepared from horse. Then combine first dose of adsorbed toxoid on one arm and second dose of the ADS, that is anti-diphtheric serum, on the other arm, and then followed by the complete active immunization. So this is combined time prophylaxis. In adult immunization, the DT vaccine is used, that is tetanus toxoid and adult diphtheria toxoid. So more than 18 years of the adult who have completely followed the primary vaccination schedule. So in that, booster dose once every 10 years is given till the age of 65. And who have not completed their primary vaccination schedule, in that 3 doses of DT is given, 0, 1, 0, 1 month and 1 year. The adverse reactions following DPT can be mild or severe. So in mild, there can be fever and local reaction, that is swelling and induration. In severe type, whole cell killed vaccine of B pertussis is encephalotogenic. So it can cause neurological symptoms. Hence, DPT is not recommended after 6 years of age. Absolute contraindication of the DPT is hypersensitivity to previous dose or progressive neurological disorder.
Hope you find this session useful for your understanding and for your exams. Thank you.